Hi, I'm Dr. Sherman Silber from the Infertility of St. Louis in the United States, and I'm honored once again to give a talk at the Asian Ovarian Club, where so many advances have been first presented. That's my email address, and I'm happy for you to send me any inquiry, any information, happy to send it back to you, because I can't cover everything today. But it's basically ovary transplantation and how it's led to our understanding of in vitro genesis, in vitro maturation, and indeed ovarian longevity. We've elucidated now the basis of ovarian longevity. And I'll start by showing a very emotional video.
There's never been any doubt in my mind that I wouldn't be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I'll get through it.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital, and we're about to do the first case in the St. Louis area of ovarian tissue freezing. Okay, well, I'm Dr. Silber, Sherman Silber, the Infertility Center of St. Louis, and we really have a treat right now. This is Jennifer, who at 24 years of age, I'm right on that, came down with a terrible case of leukemia. They thought she was going to die, but just to be safe, in case she lived, once she did, and was cured, we would freeze her ovarian tissue. So that was like 20 years ago. And this is the first case that we ever did. And we're the only ones right now really actively with a program in the whole United States. And it's been a long time. And we didn't know that we'd be able to transplant the tissue back. And we didn't know if we could culture the tissue. And here she is now. We had her on Facebook Live several months ago. And she was happily pregnant. And now look what we have. Now she's 44 years old, if I can reveal that, with a 24-year-old ovary and beautiful baby. What's her name again?
Madeline Grace.
Madeline Grace.
So I think that video just shows you very emotionally what this is all about, how to preserve fertility in cancer patients, or in fact for anyone, because here is a 44-year-old woman with a 20-year-old ovary who got pregnant spontaneously, easily, once we transplanted that frozen tissue back to her 20 years later. So I thought that video really emotionally hits the point. So we've learned how the ovary really works and have a new understanding from in vitro genesis and ovary transplantation, how it works and how we can make it live longer. What started this whole thing originally was an unusual series of identical twins discordant for ovarian failure. That's what led to it back in actually 2004, a long time ago. So crystal eggs were quite fertile at 46 years of age even, but Bonnie was born with no eggs. So the question is, we wanted to know why. We weren't thinking even about ovarian longevity. We just wanted to understand this mystery of identical twins discordant for ovarian failure. In fact, after we did the ovary transplant, you can see at age 46, she had her third baby at age 46 from this ovary transplanted from her sister who was fertile. And now at age 55, we can even make young germ cells for her so she could have more than 3 babies. Let me explain this. If the original question, if the reason for discordancy for ovarian failure in identical twins is misallocation at the time of splitting in the epiblast, we could determine in the human embryo when germ cell specification occurs by the obstetric history. And that was our goal. Was this caused by misallocation at the time of splitting, or was it genetic? And in fact, from that, can we conclude when germ cell specification occurs in the human? If we could generate germ cells from skin biopsy derived iPS cells of these women, that would rule out an epigenetic or genetic error causing the POI, leaving the only explanation to be germ cell misallocation at the time of splitting. So we started a whole program. It's called the CHOSE team, and that involved Katsuhiko Hayashi, who was the first to make normal oocytes from skin cells in the mouse. Amanda Clark, the first to make competent PGCs or germ cells with our program from humans, and Kyle Orwig, who's working on a similar process in the male. And my assistant is Sierra Goldstein. And there I am, actually being the one that does the clinical work and does the skin biopsies. So there I am with Katsuhiko Hayashi. We've been working together for a long time, for 10 years, working on actually first just the issue of what determines recruitment of primordial follicles, which in the long run will tell us what determines how long the ovary is going to survive, what determines recruitment, and what determines actually the arrest of meiosis even in the fetus. And that's Katsuhiko along with Ori Hikabe, who together did the first case of iPS cells derived from skin biopsy in a mouse, which resulted in normal oocytes, which resulted in healthy baby mice and a mother that had no ovaries. And this is Amanda Clark, and she is in charge of us trying to apply Katsuhiko's basic science work on the mouse to the human. And we're really making gigantic progress. I mean, we're almost there. You'll be shocked to hear that. So the CHOSE project involves in the mouse, first make iPS cells, that's embryonic stem cells from skin cells of the mouse's tail. These iPS cells are then transformed to PGC, primordial germ cells, incubate these primordial germ cells with fetal granulosa cells to get fully competent oocytes in normal baby mice, and it's been done. And applying this to the human, we now have many beautiful PGCs derived from a simple skin biopsy of menopausal women, very old women, and these are young PGCs. So now we just need to make fetal granulosa cells in the human so that we can complete the process of coming up with human oocytes derived from skin biopsies in older women. And these should be young, healthy oocytes, and I'll explain to you why in a second. First, this is how we do the biopsy, a simple punch biopsy, no big deal procedure for the patient. Goes to the UCLA lab, and Amanda's people keep on generating PGCs from these skin cells that are absolutely normal PGCs. This was our first publication. And then the second publication just came out that goes into massive detail. Oh, by the way, it's Sierra Goldsmith, not Goldstein. I mispronounced that. But this paper was just recently published, and it gives you the detailed formula for how to make primordial germ cells just from a skin biopsy in the human. And these cells have been tested in every way imaginable. They're completely normal cells. So we're really replaying early embryonic formation of oocytes. It all begins at the epiblast, and we're just recreating embryology. And that's why these will be very young oocytes. Oocytes generated in vitro from iPS cells will be very young. So in the future, a 38-year-old woman might be better off having a skin biopsy than an oocyte retrieval for IVF. Kind of remarkable, but it's true. But we wanted to answer our question by dating monozygotic twins splitting. We want to answer our question of when germ cell specification occurs in the early human embryo. And since all of these identical twins discordant for ovarian failure were originally monoamniotic and monochorionic, we know that only 2% are like that, and these two are in that these are in that category. And so that means that epigenetic, or that is epiblast determination, specification of germ cells occurs between 9 and 12 days in the human embryo. So what about ovary transplant for cancer patients? That was the original idea that had great clinical value, but what does it tell us about ovarian longevity and how does it work? Well, first place, we know that all the primordial follicles, 200,000 of them in a teenager, are located just in the cortex. And we also know the cortex is the toughest fibrous tissue in the body. And the inside of the ovary is just loose areolar tissue. It's like a soft place for the follicles to develop and mature internally before they then bust through the exterior surface as Graafian follicles. Now, we can see fresh human tissue primordial follicles pre-phase and post-vitrification or even slow freeze, and there is no difference. There's no damage to these eggs by the freezing process. So when we thaw the tissue, we first quilt the pieces together that we thawed. These are vitrified, thawed pieces of tissue, and we quilt it together because we think that the operation is only going to get great results if you do it in a microsurgical way that mimics what happens in reality. And in reality, we want the fallopian tube to be able to reach over and pick up the oocyte whenever it is ovulated from that transplanted ovarian cortex. That's critical. So we do it microsurgically, make no adhesions, and all of our pregnancies have been spontaneous pregnancies because IVF is very tricky in these cases, and you won't get a high success rate, but we do get a high success rate just with spontaneous pregnancy. So our overall results, we have 30 healthy babies so far, just in one clinic, in our clinic, from ovary transplant, and just as many from slow freeze as from vitrification. And this is a busy chart, but shows you how we're keeping track. And these all different kinds of cancers. And 76% of these women wind up getting pregnant with a healthy delivery, not just a miscarriage. And we have a total of 19 babies from 17 cases so far that have undergone transplantation. And that even includes leukemia. Again, you can see 2/3 of leukemia patients got pregnant after ovary transplant. We have 6 babies. These were 3 cases and no transmission of leukemia. And in fact, all of these transplants are still functioning. And we'll show, actually, I don't have that slide, but one of them from the acute myeloid leukemia is functioning 10 years later still, and she's already had 5 babies. So how do we do in vitro maturation of ovarian tissue derived oocytes? When we base it on in vitro oogenesis and on what we predict is the longevity of the ovary, what causes longevity of the ovary. And this may be the most important slide I'm showing, so take a close look at it. I've abstracted this from what we know from in vitro oogenesis, and this gives you an idea why IVM is so easy to do from ovarian tissue, actually, and also gives you a kind of a summary of how the ovary really works. So the primordial follicle really is going to be recruited and take about 4 months to a phase called IVD, or in vitro differentiation, and differentiate into GVs, actually, that are able to be responsive to gonadotropin. And that's a 4-month process. It's inexorable, and it's gonadotropin insensitive. So when you do an ovary transplant, you don't see anything happening until 4 months usually, and that's when they begin to menstruate. But there is a critical 11-day period of exposure to gonadotropin. We found that out with our in vitro oogenesis, and less than 7 days of exposure to gonadotropin in vitro, you don't get any maturation with HCG. And more than 11 days of exposure to gonadotropin, then you just get degeneration with HCG. So there is a sweet spot of 4 out of 11 or 12 days in that gonadotropin sensitive period that correlates with a 35% IVM maturation rate from the GVs derived from ovary tissue, because it's a constantly moving process, dynamic process. And so any ordinary IVF culture media works. We don't need special IVM media. You use protein as usual, and any concentration of HCG works, and any concentration of FSH works, or even Menopur, which is a terribly low concentration of HCG, works. All of these work, and that's because we know from our work with in vitro oogenesis that the ovary is constantly providing this preparation for simple IVM during the IVG phase after IVD. And so this is how we do it. We dissect the ovary tissue, preparing the cortex for freezing, but we do not throw away the spent media. In fact, we look through the spent media and we'll usually find many GV oocytes with their cumulus intact, ready for IVM. And we'll look at the histology to understand why dissection gives you such a better result with IVM than using a needle stick. first place, you can see that these most of these GVs are located close to the cortex. They've just matured and been recruited in the last 4 months from those primordial follicles, and you can see them lined up, and you see one of them right here, right next to that phase, and notice it's in the portion of the ovary where the cortex density is less. And here you can see a perfectly good GV, and they develop and migrate toward the inside of the ovary, not toward the outside. And this is a slide I borrowed from Klaus Anderson, who recently showed that you need FSH receptors for the IVM to work. And the FSH receptors are really located in the mural granulosa cells, not really in the cumulus granulosa cells. And so that's why if you just did a needle stick, you would most likely not get all those mural granulosa cells. But when we do it surgically, and I'll show you again, when we do it surgically, we're going to get all of the mural as well as the other cells. So that's why we have such fantastic results. And just putting it in HCG of any concentration goes from what looks like this with a tight cumulus and a GV, and there the next day you have good quality M2 oocytes, just like we do in the mouse using the same period of time. It's remarkable. It's the same sweet spot on the mouse, and you get normal metaphase 2 oocytes. And this is a summary of our first 13 cases. We now have over 30 of these cases, and you can see the IVM rate is consistently in the neighborhood of 35%. And that fits with the sweet spot. The 7 out of 11 days we know from in vitro oogenesis, that is the sweet spot of exposure to gonadotropin in vivo. And that's why a simple day or two of exposure to HCG will result in maturation to normal M2 oocytes in 35% of the cases. So many mature oocytes can be obtained from ovary tissue with simple media, no need for ovary stimulation, but the intact cumulus is crucial. Now, this rate of 32% and 31% and 39% and 30% from everybody doing this work, Hayashi, Seegers, Klaus Anderson, and us, is very, very consistent that you can expect, if you do this right, with any concentration of gonadotropin or HCG, to have a 30 to 39% maturation rate, because that's the sweet spot that we determine from in vitro oogenesis. Now, Anderson checked the aneuploidy or euploidy of these eggs, and it turns out that the euploidy is just the same as any eggs that you would get from ovarian stimulation. And there have been live births following this. It takes a while before patients come back to use these eggs and are cured of their cancer, but certainly we've had many live births from this. So these are healthy oocytes. So why does it not require special IVM media, and why does IVM really work? And to understand why IVM works, you must understand in vitro gametogenesis. So this is me at my birthday. I think it was maybe my 77th birthday. I can't remember, in Japan with Katsuhiko's group when they were in the southern part of Japan, and now they're in Osaka. And we worked together for many years. And this guy right here, Hamazaki, is the one who found that if you reduce the pressure of the cortex, you can't stop these primordial follicles from being recruited and developing. You just can't stop it. So we'll go into a little more detail about that, because that relates to ovarian longevity. So GV oocytes dissected from ovary tissue have already become meiotically competent in vivo by what we term IVD and IVG. And also, it is far easier to get many GV oocytes from tiny follicles using open cortical dissection than a needle. But also, a third thing I haven't had time to add here yet is Klaus Anderson's point that you really need the mural granulosa cells as well as the cumulus, maybe even more importantly than the cumulus granulosa cells. So now this is just a short summary of the Hikabe et al. Paper in 2016 that I was part of and saw the original pups. And this is where we first made healthy mice from the skin cells of their mother. And it all begins here in the epiblast. As I said before, PGC specification occurs early. So we know these will be young oocytes. And we know as the primordial cells begin to move toward the dorsum, that's when they begin to differentiate into PGCs. And if they haven't differentiated fully into PGCs, when they reach the ovary, they'll become germ cell rests and become tumors later in life. 95% of them have to have matured, or that is differentiated. And they do that during this process of moving from the yolk sac outside the embryo from PGC specified cells to PGCs. And I'm not going to go through this. I don't have the time, but I can always send you the slide. But for making an oocyte in vitro, it's just a standard exposure. But I want you just to look at, once we have PGC or PGC-like cells, they're exposed to granulosa cells for 3 weeks, and they have to be fetal granulosa cells. They can't be adult. And that we call IVD. That's where the granulosa cells allow that PGC to actually become oocyte capable of being responsive to a gonadotropin. And then FSH culture for 11 days, and that's what we call IVG. And then HCG culture just for a day, plus some FSH is what we call IVM. Why do we need plus FSH? Because Klaus Anderson showed very clearly you need FSH to upregulate those LH receptors so that you can get maturation. And this is Hikabe and Hayashi's original diagram. And I won't go through the busyness of it, though I could later to people that are interested. But you can see they've got the IVD phase, where the oogonia are actually incubated with fetal granulosa cells. In the humans, it's 4 months. In the mouse, it's 21 days. But then it's remarkably constant in all animals, the amount of exposure to IVG, which is usually 11 to 14 days. Now, if it's not enough, then they won't mature, and if it's too much, then they will degenerate. Now, this IVG exposure in the original studies only involved exposure to FSH, but now we know that we have to put a little LH in also, just like in the human, to get the best results. And these are the first mouse pups, totally normal, healthy, born from skin fibroblasts derived from their mother. And this, I'll repeat again, this is the diagram. You always have to remember that at any given time in the ovary, it's a dynamic process. There will be oocytes that have been exposed to IVG and they've finished their exposure to the granulosa cells and that 4 month period of inexorable development from primordial. But in that 11-day period, there will be 35% of them that have been exposed for more than 7 days and less than 11 days, and there will be the ones that will mature in vitro. So oocytes in the human ovary, 4.5 months after recruitment, have completed IVD and IVG and are ready for IVM. And this is a constantly changing dynamic. In vivo, once the oocytes have completed IVG, they are meiotically competent and ready for HCG or the LH surge. And this is a constant daily process. Secondary follicles that just finished IVD are now gonadotropin sensitives. And these are the ones that will enlarge with ovarian stimulation. But new secondary follicles are appearing every day, an average of 30 days after finishing IVD, and are now gonadotropin sensitive and begin their FSH-induced IVG. GVs that have finished IVG are now meiotically competent and ready for HCG. So in an ovulatory cycle where one lead follicle becomes dominant, the non-dominant follicles still are going through IVG and attain meiotic competence. So why do we even need ovary stimulation at all? We really don't need it, other than we do need it, and we need the ovulatory cycle simply for follicle enlargement and to get the oocyte out of the ovary. That's the only reason. It's not for maturation. That's going to happen anyway. We need to increase the follicle size and be able to get the egg out of the follicle. So what is it that determines ovarian longevity, now that we know this much? It's resting follicle recruitment and ovarian longevity are regulated by tissue pressure. Now, if you look at this original diagram by Hayashi with the mouse, In vivo, we automatically go from PGC to oogonia, meiosis, primary follicle, secondary follicle, intrafollicle. But in vitro, we find that if we use the ovarian tissue, we find that the primordial follicles are locked, and they just will not develop. They will not develop at all unless you do something to make them develop. And so if you take a piece of tissue, it's harder to develop an egg, really, than to develop an egg just from stem cells. But let's understand this better. After ovary transplant, we found that at 4 months, there was a huge rise in AMH as the FSH came down to more normal levels. And then the AMH went down again 4 or 5 or 6 months later. And these pieces of tissue can last 10 years or longer with a low ovarian reserve. But what happened, obviously, is there was initially a huge recruitment of primordial follicles because of release of tissue pressure when we did the transplant. But nonetheless, then it eventually stabilizes, and you can have very long-lasting ovary transplants. This is our composite graph of the same thing. And this is an embryologic study that was done by Biscoff and Klaus Anderson many, many years ago, showing that in the fetal ovary and in the newborn and in the early fetal ovary, the oocytes that go to the cortex, they become very small and they become primordial follicles and they're arrested. But the ones that don't go to the cortex die off. They develop, they are recruited, and then they're gone. The only ones that are really preserved are the ones that reach the cortex. And so also, how can these ovaries function so long with a low AMH? Well, Wallace showed very well that the rate of primordial follicle recruitment goes down as the ovarian reserve goes down. So the ovary tissue will last longer when it has less primordial follicles in it. And we'll get into why that is. But so you could take you could freeze ovary tissue in a cancer patient, transplant one back, and it would last 10 years. And 10 years later, transplant another one back, and it'll last 10 years. And you'll be able to have about 5 transplants. So you can get 50 years of function out of just one ovary because of this concept that Wallace first showed. And so how do we really prove that stress and pressure is the problem? So Nagamatsu, who I showed you before, went into a direct study in which he showed mechanical stress in vitro accompanied with nuclear rotation is involved in the dormant state of mouse follicles. So transcriptional histological analysis revealed that oocytes were compressed by surrounding granulosa cells with this tough extracellular matrix. And this environmental state is functionally crucial as oophytes became activated upon loosening the structure, and the dormancy was restored by additional compression with exogenous pressure. So, for example, the dormant oocytes, will show you the nuclei rotate towards the cortex, but recruited oocytes, the nuclei stop rotating. So there you see the nuclei rotating in the outer cortex in the primordial follicles that have not been recruited, but the nuclei are static internally in the developing follicles. Again, you can see that they're rotating and they are dormant in high pressure cortex, but in the low pressure medulla, they are not rotating. So he put a culture chamber together where he cultured these oocytes that were devised from iPS cells, and under high pressure, they stopped developing, and under low pressure, they began developing again. And this is a diagram, and many engineers have found this now in stem cells throughout the body, somatic stem cells. It's the same thing is happening. They respond to myotonic pressure, and in response to myotonic pressure, the nuclei rotate, and then they are dormant. So what controls the recruitment of follicles in adults from a resting phase is a gradual release from the fibrous tissue, tough fibrous tissue of the cortex. And I'll show you that just in like every case you want to do ovary freezing on, you can see more dense, less dense, and least dense stroma. So that pressure gradient allows for the recruitment and development of the primordial follicles. Now, another study to prove this was done by Teramoto in 2016, in which he followed for 16,000 women, so the statistics are very good on it, their AMH level over time from age 28 to 46. And what happened to that AMH level whenever they were pregnant. And when they were pregnant, the AMH stopped declining. And the decline was remarkable. 13 and a half months from pregnancy until they were 3 months post-pregnancy, the AMH stopped declining. And this was shown by McCready also in 2017, that during pregnancy, the AMH stops. The AMH is going down initially, but then it goes up again after the pregnancy is released. So what's happening is that the pressure of the pregnancy is causing the primordial follicle recruitment to be decreased, and once there's a delivery, then the primordial follicles are increased again. So we don't just need pressure, we need 8 core genes, and this is the secret to ovarian longevity, these 8 core genes. And this was part of Hamazaki's work also in Nature. And these are the 8 core genes. Now, there are many downstream genes involved in the IVD phase of maturing that primordial follicle into a GV. But like SRY, which does not construct the testes, but just triggers many downstream genes, these are the 8 minimal core genes that trigger all the other complexity of downstream genes that will turn the primordial follicle into an egg that is sensitive to gonadotropin over a 4-month period. So we call these PPT8 genes. They recruit primordial follicles to grow direct to secondary follicles, quite competent. All you need are these genes to unlock the primordial follicle and let them develop the IVG phase, quite competent. But no, primordial follicles have already gotten through the fetal granulosa cell stage. Fetal granulosa cells are critical. So they have meiotic competence and have undergone erasure of imprinting. And so the PPT8 genes are all you need to recruit primordial follicles. However, these oocytes are functionally competent to make normal offspring because of their prior exposure to granulosa cells. However, when cultured with PGCs, you get incompetent oocytes because of no prior exposure to fetal granulosa cells. So you take PGCs, no fetal granulosa cells, incubate them with these 8 core genes, and you get what looks like perfectly normal oocytes, except they can't go through meiosis. They look perfectly normal. They can't go through meiosis because they never had that exposure to fetal granulosa cells. So we still need fetal granulosa cells. The PPT8 factors promote oocytes to receive nutrition from granulosa cells, but we still need fetal granulosa cells. Now we have them. Yoshino et al. Finally showed in 2021 through using reverse transcriptase determination of genes at every stage of embryonic development to oocytes, that he could mix these cells that were exposed to PPT8 genes. He could mix the PGC-like cells with them, and he calls them fossils. But basically, these are fetal granulosa-like cells that were developed from a similar culture process, but not the 8 core genes, to a different series of genes. And so now you can make a culture where you have fetal granulosa cells, and a culture where you have PGCs, put them together, and you get normal oocytes. And this is going to allow us to do it in humans, because we don't have to go to abortion clinics to try to find fetal granulosa cells. We can make fetal granulosa cells from the same skin biopsy we use to make the PGCs. And this was actually an editorial in New England Journal of Medicine this year, talking about Yoshino, who worked with Hayashi, his work. And look at the bottom part, you see the whole idea is you differentiate to PGC-like cells in one direction, and to fetal ovarian somatic cells or fetal granulosa cells in another culture, and you put them together, you reconstitute them, you get a completely normal egg and normal offspring from these eggs that were developed simply from skin cells. This is my last slide, but what we learned with the studies of the allotransplant is the ovary tissue graft can survive on diffusion alone without revascularization. And we learned the ease of IVM from these cases derived from our understanding now of in vitro gametogenesis via Hayashi. And this clarifies our understanding of the mechanism of primordial follicle recruitment plus follicle and oocyte developmental stages. So this is really the basis of ovarian longevity. We can do it practically in humans with ovary freezing and transplantation, and we can do it in vitro even by developing iPS cells or stem cells really into competent oocytes that can make estrogen and allow the ovary to live indefinitely. Thank you very much for allowing me to give this talk here.